Insulin therapy in diabetes. A comprehensive overview of indications, regimens, administration routes, monitoring, and complications of insulin therapy. Insulin therapy is indicated whenever the body cannot produce enough insulin or when rapid and reliable glucose control is required. In type 1 diabetes mellitus, insulin is essential because these patients have an absolute insulin deficiency. Without insulin, survival is not possible. In type 2 diabetes mellitus, insulin is used when oral anti-diabetic drugs fail to achieve adequate glycemic control, or when patients present with severe hyperglycemia. It is also indicated during periods of acute illness, surgery, or severe physiological stress. Pregnancy and gestational diabetes are additional situations where insulin is often preferred due to its safety profile. Finally, insulin is the treatment of choice for diabetic emergencies such as diabetic ketoacidosis and hyperosmolar hyperglycemic state, where prompt correction of hyperglycemia is critical. Insulin can be administered using several different regimens depending on the patient's needs and treatment goals. Basal insulin regimen uses a long-acting insulin such as glargine, datamir, or degludec administered once daily. It primarily controls fasting blood glucose levels by suppressing hepatic glucose production and is commonly used in patients with type 2 diabetes when oral anti-diabetic drugs fail to achieve adequate glycemic control. The basal bolus regimen combines a long-acting basal insulin with rapid-acting insulin analogs such as Lispro, Aspart, or Glulicin administered before meals. This approach closely mimics normal physiological insulin secretion and provides comprehensive control of both fasting and postprandial blood glucose levels. Premixed insulin preparations contain fixed combinations of short-acting and intermediate-acting insulin. They are typically administered twice daily before meals and offer a simpler dosing schedule. A common example is the 70-30 insulin mixture. An insulin pump delivers a continuous basal supply of insulin throughout the day, along with additional bolus doses at mealtimes. This method provides highly precise insulin delivery and is used primarily in patients with type 1 diabetes mellitus. Insulin is most commonly administered by the subcutaneous route, which provides reliable absorption for long-term diabetes management. In emergencies such as diabetic ketoacidosis and hyperosmolar hyperglycemic state, insulin is administered intravenously to achieve rapid and precise glucose control. A newer option is inhaled insulin, such as a technosphere insulin, which is absorbed through the lungs and used primarily for mealtime or prandial glucose control. However, it doesn't replace the need for basal insulin in patients who require it. Insulin is most commonly administered by subcutaneous injection, and the choice of injection site can influence the rate of absorption. The abdomen is generally the preferred site because it provides the fastest and most consistent absorption, making it ideal for most insulin injections. The thigh offers slower but steady absorption and is commonly used for intermediate-acting and long-acting insulin preparations. The upper arm provides an intermediate rate of absorption, falling between the abdomen and thigh. The buttock has the slowest absorption and may be useful when a prolonged effect is desired. To ensure consistent insulin action and prevent lipodystrophy, patients should regularly rotate injection sites within the same anatomical region. Monitoring during insulin therapy involves regular assessment of blood glucose levels to evaluate day-to-day glycemic control and periodic measurement of HbA1c to assess long-term glucose control. Patients should also be closely monitored for signs and symptoms of hypoglycemia, which is the most common adverse effect of insulin therapy. Insulin doses should be adjusted as needed based on changes in diet, physical activity, intercurrent illness, and other factors that can influence insulin requirements. Although insulin is highly effective, it can be associated with several adverse effects and complications. The most common and clinically important complication is hypoglycemia, which can range from mild symptoms such as sweating and tremors to severe neurological impairment. Weight gain may occur because insulin promotes fat storage through its anabolic effects. Repeated injections at the same site can lead to lipodystrophy, causing localized changes in subcutaneous fat that may interfere with insulin absorption. Insulin also drives potassium into cells, which can result in hypokalemia, particularly during intravenous insulin therapy. Finally, allergic reactions may occur, although they are uncommon with modern human insulin preparations. These reactions can be localized to the injection site or rarely become systemic. To conclude, successful insulin therapy requires an individualized approach, tailored to each patient's clinical condition and glycemic goals. The choice of regimen should be based on the type of diabetes, lifestyle, and treatment requirements. Equally important is consistent monitoring, including regular blood glucose measurements, periodic HbA1c assessment, and vigilance for hypoglycemia. Finally, clinicians and patients must proactively manage potential complications such as hypoglycemia, weight gain, and injection site problems through proper education and monitoring and dose adjustments.